Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Andexanet for factor SA inhibitor, associated acute intracerebral hemorrhage. Background. Patients with acute intracerebral hemorrhage, who are receiving factor SA inhibitors, have a risk of hematoma expansion. The effect of Andexanet alpha, an agent that reverses the effects of factor SA inhibitors, on hematoma volume expansion, has not been well studied. Methods. We randomly assigned, in a 1-to-1 ratio, patients who had taken factor SA inhibitors within 15 hours, before having an acute intracerebral hemorrhage to receive Andexanet or usual care. The primary endpoint was hemostatic efficacy, defined by expansion of the hematoma volume by 35% or less, at 12 hours after baseline, an increase in the score on the National Institutes of Health stroke scale, of less than 7 points. Scores range from 0 to 42, with higher scores indicating worse neurologic deficit, at 12 hours, and no receipt of rescue therapy between 3 hours and 12 hours. Safety endpoints were thrombotic events and death. Results. A total of 263 patients were assigned to receive Andexanet, and 267 to receive usual care. Efficacy was assessed in an interim analysis that included 452 patients, and safety was analyzed in all 530 enrolled patients. Atrial fibrillation was the most common indication for factor SA inhibitors. Of the patients receiving usual care, 85.5% received prothrombin complex concentrate. Hemostatic efficacy was achieved in 150 of 224 patients, 67.0%, receiving Andexanet, and in 121 of 228, 53.1%, receiving usual care. Adjusted difference, 13.4 percentage points, 95% confidence interval, CI, 4.6 to 22.2, p equals 0.003. The median reduction from baseline to the 1 to 2 hour nadir in anti-factor SA activity was 94.5% with Andexanet and 26.9% with usual care, p less than 0.001. Thrombotic events occurred in 27 of 263 patients, 10.3%, receiving Andexanet, and in 15 of 267, 5.6%, receiving usual care. Difference, 4.6 percentage points, 95% CI, 0.1 to 9.2. P equals 0.048. Ischemic stroke occurred in 17 patients, 6.5%, and 4 patients, 1.5% respectively. There were no appreciable differences between the groups in the score on the modified Rankin scale, or in death within 30 days. Conclusions. Among patients with intracerebral hemorrhage who were receiving factor SA inhibitors, Andexanet resulted in better control of hematoma expansion than usual care, but was associated with thrombotic events, including ischemic stroke. Perioperative Nivolumab in resectable lung cancer. Background. Standard treatment with neoadjuvant Nivolumab plus chemotherapy significantly improves outcomes in patients with resectable non-small cell lung cancer, NSCLC. Perioperative treatment, i.e., neoadjuvant therapy followed by surgery and adjuvant therapy with Nivolumab, may further improve clinical outcomes. Methods. In this Phase 3, randomized, double-blind trial, we assigned adults with resectable stage IA to FIB NSCLC to receive neoadjuvant crash, Nivolumab, plus chemotherapy, or neoadjuvant chemotherapy, plus placebo every 3 weeks for 4 cycles, followed by surgery and adjuvant Nivolumab or placebo every 4 weeks for 1 year. The primary outcome was event-free survival, according to blinded independent review. Secondary outcomes were pathological complete response and major pathological response, according to blinded independent review, overall survival, and safety. Results. At this pre-specified interim analysis, median follow-up, 25.4 months. The percentage of patients with 18-month event-free survival was 70.2% in the Nivolumab group and 50.0% in the chemotherapy group. Hazard ratio for disease progression or recurrence, abandoned surgery, or death, 0.58, 97.36% confidence interval, CI, 0.42 to 0.81, p less than 0.001. A pathological complete response occurred in 25.3% of the patients in the Nivolumab group and in 4.7% of those in the chemotherapy group. Odds ratio, 6.64, 95% CI, 3.40 to 12.97. A major pathological response occurred in 35.4% and 12.1%, respectively. Odds ratio, 4.01, 95% CI, 2.48 to 6.49. Grade 3 or 4 treatment related adverse events occurred in 32.5% of the patients in the Nivolumab group and in 25.2% of those in the chemotherapy group. Conclusions. Perioperative treatment with Nivolumab resulted in significantly longer event-free survival than chemotherapy in patients with resectable NSCLC. No new safety signals were observed. Olezarsen for hypertriglyceridemia in patients at high cardiovascular risk. Background. Reducing the levels of triglycerides and triglyceride-rich lipoproteins remains an unmet clinical need. Olezarsen is an antisense oligonucleotide targeting messenger RNA for apolipoprotein C3, APOC3, a genetically validated target for triglyceride lowering. Methods. In this Phase 2b, randomized, controlled trial, we assigned adults either with moderate hypertriglyceridemia, triglyceride level, 150 to 499 mg per deciliter, and elevated cardiovascular risk, or with severe hypertriglyceridemia, triglyceride level, greater than or equal to 500 mg per deciliter, in a 1-to-1 ratio to either a 50 mg or 80 mg cohort. Patients were then assigned in a 3-to-1 ratio to receive monthly subcutaneous Olezarsen or matching placebo within each cohort. The primary outcome was the percent change in the triglyceride level from baseline to 6 months, reported as the difference between each Olezarsen group and placebo. Key secondary outcomes were changes in levels of APOC3, apolipoprotein B, non-high-density lipoprotein, HDL, cholesterol, and low-density lipoprotein, LDL, cholesterol. Results. A total of 154 patients underwent randomization at 24 sites in North America. The median age of the patients was 62 years, and the median triglyceride level was 241.5 mg per deciliter. The 50 mg and 80 mg doses of Olezarsen reduced triglyceride levels by 49.3 percentage points and 53.1 percentage points, respectively, as compared with placebo, p less than 0.001 for both comparisons. As compared with placebo, each dose of Olezarsen also significantly reduced the levels of APOC3, apolipoprotein B, and non-HDL cholesterol, with no significant change in the LDL cholesterol level. The risks of adverse events and serious adverse events were similar in the three groups. Clinically meaningful hepatic, renal, or platelet abnormalities were uncommon, with similar risks in the three groups. Conclusions. In patients with predominantly moderate hypertriglyceridemia at elevated cardiovascular risk, Olezarsen significantly reduced levels of triglycerides, apolipoprotein B, and non-HDL cholesterol, with no major safety concerns identified. Olezarsen, acute pancreatitis, and familial chylomicronemia syndrome. Background. Familial chylomicronemia syndrome is a genetic disorder associated with severe hypertriglyceridemia and severe acute pancreatitis. Olezarsen reduces the plasma triglyceride level by reducing hepatic synthesis of apolipoprotein C3. Methods. In a Phase 3, double-blind, placebo-controlled trial, we randomly assigned patients with genetically identified familial chylomicronemia syndrome to receive Olezarsen at a dose of 80 mg or 50 mg, or placebo subcutaneously every 4 weeks, for 49 weeks. There were 2 primary endpoints: the difference between the 80 mg Olezarsen group and the placebo group in the percent change in the fasting triglyceride level from baseline to 6 months, and, to be assessed if the first was significant, the difference between the 50 mg Olezarsen group and the placebo group. Secondary endpoints included the mean percent change from baseline in the apolipoprotein C3 level and an independently adjudicated episode of acute pancreatitis. Results. A total of 66 patients underwent randomization. 22 were assigned to the 80 mg Olezarsen group, 21 to the 50 mg Olezarsen group, and 23 to the placebo group. At baseline, the mean, plus or minus, triglyceride level among the patients was 2630 plus or minus 1315 mg per deciliter, and 71% had a history of acute pancreatitis within the previous 10 years. Triglyceride levels at 6 months were significantly reduced with the 80 mg dose of Olezarsen, as compared with placebo, minus 43.5 percentage points, 95% confidence interval, CI, minus 69.1 to minus 17.9. P less than 0.001, but not with the 50 mg dose, minus 22.4 percentage points, 95% CI, minus 47.2 to 2.5. P equals 0.08. The difference in the mean percent change in the apolipoprotein C3 level from baseline to 6 months in the 80 mg group, as compared with the placebo group, was minus 73.7 percentage points, 95% CI, minus 94.6 to minus 52.8, and between the 50 mg group, as compared with the placebo group, was minus 65.5 percentage points, 95% CI, minus 82.6 to minus 48.3. By 53 weeks, 11 episodes of acute pancreatitis had occurred in the placebo group, and 1 episode had occurred in each Olezarsen group. Rate ratio, pooled Olezarsen groups versus placebo, 0.12. 95% CI, 0.02 to 0.66. Adverse events of moderate severity that were considered by a trial investigator at the site to be related to the trial drug or placebo occurred in 4 patients in the 80 mg Olezarsen group. Conclusions. In patients with familial chylomicronemia syndrome, Olezarsen may represent a new therapy to reduce plasma triglyceride levels. Next, we will be discussing articles from Journal of American Medical Association. Text messages with financial incentives for men with obesity. A randomized clinical trial. Importance: effective weight loss interventions are needed for men with obesity. Objective: to determine whether an intervention that combined text messaging with financial incentives attained significant weight loss at the 12-month follow-up, compared with the control group, and whether an intervention of text messaging alone attained significant weight loss at the 12-month follow-up, compared with the control group. Main outcomes and measures. The 2 primary comparisons were the 12-month comparison of within participant weight change between the text messaging with financial incentive group and the control group, and the comparison between the text messaging alone group and the control group. Minimum clinically important difference, 3%. The p-value defined for statistical significance was p less than 0.025 for each comparison. Results of the 585 men, mean, SD, age, 50.7, 13.3 years, mean weight, 118.5, 19.9 kg, mean BMI, 37.7, 5.7, 525, 90%, white, 227, 39%, lived in postal code areas with lower socioeconomic status, and 426, 73%, completed the 12-month follow-up. At the 12-month follow-up, compared with the control group, the mean percent weight change was significantly greater in the text messaging with financial incentive group, mean difference, minus 3.2%, 97.5% CI, minus 4.6% to minus 1.9%, p less than 0.001, but was not significantly greater in the text messaging alone group. Mean difference, minus 1.4%, 97.5% CI, minus 2.9% to 0.0, p equals 0.05. The mean, SD, weight changes, were minus 5.7, 7.4 kg for the text messaging with financial incentives group, minus 3.0, 7.5 kg for the text messaging alone group, and minus 1.5, 6.6 kg for the control group. The 12-month mean SD percentage weight changes from baseline were minus 4.8%, 6.1%. For the text messaging with financial incentives group, minus 2.7%, 6.3%, for text messaging alone group, and minus 1.3%, 5.5%, for the control group. Of 366 adverse events reported, the most common were infections, 83, 23%. Of the 23 serious adverse events, 6.3%, 12, 52%, occurred in the text messaging with financial incentives group, 5, 22%, in the text messaging alone group, and 6, 26%, in the control group. None were considered related to participating in a trial group. Conclusion and relevance among men with obesity. An intervention with text messaging with financial incentive significantly improved weight loss compared with a control group, whereas text messaging alone was not significantly better than the control condition. These findings support text messaging combined with financial incentives to attain weight loss in men with obesity. An adaptive behavioral intervention for weight loss management. A randomized clinical trial. Importance: lifestyle interventions for weight loss are difficult to implement in clinical practice. Self-managed mobile health implementations, without or with added support, after unsuccessful weight loss attempts could offer effective population-level obesity management. Objective: to test whether a wireless feedback system, WFS, yields non-inferior weight loss versus WFS, plus telephone coaching, and whether participants who do not respond to initial treatment achieve greater weight loss with more versus less vigorous step-up interventions. Design, setting, and participants. In this non-inferiority randomized trial, 400 adults aged 18 to 60 years, with a body mass index of 27 to 45, were randomized in a 1-to-1 ratio to undergo 3 months of treatments. Initially with WFS or WFS, plus coaching at a U.S. academic medical center between June 2017 and March 2021. Participants attaining suboptimal weight loss were re-randomized to undergo modest or vigorous step-up intervention. Main outcomes and measures. The primary outcome was the between-group difference in 6-month weight change, with the non-inferiority margin defined as a difference in weight change of minus 2.5 kilograms. Secondary outcomes included between-group differences for all participants in weight change at 3 and 12 months, and between-group 6-month weight change difference among non-responders exposed to modest versus vigorous step-up interventions. Results among 400 participants. Mean SD, age, 40.5, 11.2 years, 305, 76.3%, women. 81 participants were Black, and 266 were white. SD, body mass index, 34.4, 4.3, randomized to undergo WFS, N equals 199, versus WFS plus coaching, N equals 201. Outcome data were available for 342 participants, 85.5%, at 6 months. 6-month weight loss was minus 2.8 kilograms, 95% CI, minus 3.5 to minus 2.0, for the WFS group, and minus 4.8 kilograms, 95% CI, minus 5.5 to minus 4.1, for participants in the WFS plus coaching group. Difference in weight change, minus 2.0 kilograms, 90% CI, minus 2.9 to minus 1.1, p less than 0.001. The 90% CI included the non-inferiority margin of minus 2.5 kilograms. Weight change differences were comparable at 3 and 12 months, and, among non-responders, at 6 months, with no difference by step-up therapy. Conclusions and relevance. A wireless feedback system, Wi-Fi activity tracker and scale with smartphone app to provide daily feedback, was not non-inferior to the same system with added coaching. Continued efforts are needed to identify strategies for weight loss management and to accurately select interventions for different individuals to achieve weight loss goals. Next, we will be discussing articles from Nature Medicine. Effectiveness of bariatric metabolic surgery versus glucagon-like peptide-1 receptor agonists for prevention of congestive heart failure. Comparative evidence for the effects of bariatric metabolic surgery, BMS, and glucagon-like peptide-1 receptor agonists, GLP-1RA, on cardiovascular outcomes is limited. Here, in an observational, retrospective cohort study, we compared the incidence of congestive heart failure, CHF, in adults living with obesity and diabetes without history of CHF, primary CHF, treated with BMS versus GLP-1RA. The population cohort comprised members of Clalet Health Services with no prior history of ischemic heart disease, ischemic stroke, or CHF. During the time period of 2008 to 2021, patients who underwent their first BMS were matched 1-to-1 with patients who initiated treatment with GLP-1RA, based on clinical characteristics. The study included 2,205 matched pairs of patients, 64.5% female, followed for a median of 6.6 years and up to 12 years. Primary incidence of CHF occurred in 26, 1.2%, BMS patients and in 90 GLP-1RA patients, 4.1%, adjusted HR, 0.43, 95% CI, 0.27 to 0.68. Further adjustment for weight reduction did not significantly diminish this association. HR adjusted for weight reduction, 0.48, 95% CI 0.28 to 0.82, indicating that the differential effect was not mediated through the relative advantage of BMS in maximal weight reduction. In this study, BMS was associated with a stronger reduction in primary incidence of CHF compared to treatment with GLP-1RA. With the increasing use of highly potent next-generation GLP-1RAs, further comparative long-term studies are warranted. Next, we will be discussing articles from Lancet. Intravascular ultrasound-guided versus angiography-guided percutaneous coronary intervention in acute coronary syndromes. IVUS-ACS, a two-stage, multicentre, randomized trial. Background. Intravascular ultrasound-guided percutaneous coronary intervention has been shown to result in superior clinical outcomes compared with angiography-guided percutaneous coronary intervention. However, insufficient data are available concerning the advantages of intravascular ultrasound guidance for patients with an acute coronary syndrome. This trial aimed to investigate whether the use of intravascular ultrasound guidance, as compared with angiography guidance, improves the outcomes of percutaneous coronary intervention with contemporary drug-eluting stents in patients presenting with an acute coronary syndrome. Methods. In this two-stage, multicentre, randomized trial, patients aged 18 years or older and presenting with an acute coronary syndrome at 58 centres in China, Italy, Pakistan, and the UK were randomly assigned to intravascular contents. Ultrasound-guided percutaneous coronary intervention, or angiography-guided percutaneous coronary intervention. Patients, follow-up healthcare providers, and assessors were masked to random assignment. However, staff in the catheterization laboratory were not. The primary endpoint was target vessel failure, a composite of cardiac death, target vessel myocardial infarction, or clinically driven target vessel revascularization at 1 year after randomization. This trial is registered at clinicaltrials.gov, NCT 03971500, and is completed. Findings. Between August 20, 2019, and October 27, 2022, 3,505 patients with an acute coronary syndrome were randomly assigned to intravascular ultrasound-guided percutaneous coronary intervention, N equals 1753, or angiography-guided percutaneous coronary intervention, N equals 1752. 1-year follow-up was completed in 3,504, greater than 99.9% patients. The primary endpoint occurred in 70 patients in the intravascular ultrasound group and 102. 28 patients in the angiography group, Kaplan-Meier rate 4.0% versus 7.3%, hazard ratio 0.55, 95%, CI 0.41 to 0.74, P equals 0.0001, driven by reductions in target vessel myocardial infarction or target vessel revascularization. There were no significant differences in all-cause death or stent thrombosis between groups. Safety endpoints were also similar in the two groups. Interpretation. In patients with an acute coronary syndrome, intravascular ultrasound-guided implantation of contemporary drug-eluting stents resulted in a lower 1-year rate of the composite outcome of cardiac death, target vessel myocardial infarction, or clinically driven revascularization, compared with angiography guidance alone. Next, we will be discussing articles from Journal of Clinical Oncology, Comprehensive Inherited Risk Estimation for Risk-Based Breast Cancer Screening in Women. Purpose. Family history, FH, and pathogenic variants, PVs, are used for guiding risk surveillance in selected high-risk women, but little is known about their impact for breast cancer screening on population level. In addition, polygenic risk scores, PRSs, have been shown to efficiently stratify breast cancer risk through combining information about common genetic factors into one measure. Methods. In longitudinal real-life data, we evaluate PRS, FH, and PVs for stratified screening using FinGen, N equals 117,252, linked to the Mass Screening Registry for Breast Cancer, 1992 to 2019. Nationwide organized biennial screening for age 50 to 69 years. We assessed the screening performance of a breast cancer PRS and compared its performance with FH of breast cancer and PVs in moderate, check 2, to high risk, POLB2, susceptibility genes. Results. Effect sizes for FH, PVs, and high PRS, greater than 90th percentile, were comparable in screening aged women, with similar implications for shifting age at screening onset. A high PRS identified women more likely to be diagnosed with breast cancer after a positive screening finding. Positive predictive value, PPV, 39.5%, 95% CI, 37.6 to 41.5. Combinations of risk factors increased the PPVs up to 45% to 50%. A high PRS conferred an elevated risk of interval breast cancer, hazard ratio, HR, 2.78, 95% CI, 2.00 to 3.86, at age 50 years, HR, 2.48, 95% CI, 1.67 to 3.70, at age 60 years, and women with a low PRS, less than 10th percentile, had a low risk for both interval and screen-detected breast cancers. Conclusion. Using real-life screening data, this study demonstrates the effectiveness of a breast cancer PRS for risk stratification, alone and combined with FH and PVs. Further research is required to evaluate their impact in a prospective risk stratified screening program, including cost-effective. Next, we will be discussing articles from Journal of Hepatology. Optimal hepatitis, see treatment adherence patterns, and sustained virologic response among people who inject drugs, the HERO study. Background and aims. Direct-acting antivirals, DAAs, are highly effective for treating HCV infection even among people who inject drugs, PWID. Yet, little is known about patients' adherence patterns and their association with sustained virologic response, SVR, rates. We aimed to summarize various adherence patterns and determine their associations with SVR. Methods. Electronic. Blister packs were used to measure daily adherence to once-a-day, sofosbuvir/velpatasvir, During the 12-week treatment period among active POIDs, blister pack data were available for 496 participants who initiated DAAs for whom SVR status was known. Adherence was summarized in multiple patterns, such as total adherent days, consecutive missed days, and early discontinuations. Thresholds for adherence patterns associated with greater than 90% SVR rates were also determined. Results. The overall SVR rate was 92.7%, with a median adherence rate of 75%. All adherence patterns indicating greater adherence were significantly associated with achieving SVR. Participant groups with greater than or equal to 50%, greater than 4284, adherent days or less than 26 consecutive missed days, achieved an SVR rate of greater than 90%. Greater total adherent days during 9 to 12 weeks, and no early discontinuation were significantly associated with higher SVR rates only in those with less than 50% adherence. Participants with first-month discontinuation and greater than or equal to 2 weeks of treatment interruption had low SVR rates, 25% and 85% respectively. However, greater adherent days were significantly associated with SVR. Adjusted odds ratio 1.10, 95%, CI 1.04 to 1.16, p less than 0.001. Even among participants with greater than or equal to 14 consecutive missed days. Conclusions. High SVR rates can be achieved in the POID population despite suboptimal adherence. Encouraging patients to take as much medication as possible, with less than 2 weeks consecutive missed days, and without early discontinuation, was found to be important for achieving SVR. Next, we will be discussing articles from Clinical Gastroenterology. Prospective comparison of attenuation imaging and controlled attenuation parameter for liver steatosis diagnosis in patients with non-alcoholic fatty liver disease and type 2 diabetes. Background and aims. Similarly to the controlled attenuation parameter, CAP, the ultrasound-based attenuation imaging, ATI, can quantify hepatic steatosis. We prospectively compared the performance of ATI and CAP for the diagnosis of hepatic steatosis in patients with type 2 diabetes and non-alcoholic fatty liver disease, using histology and magnetic resonance imaging, proton density fat fraction, MRI, PDFF, as references. Methods. Patients underwent ATI and CAP measurement, MRI, and biopsy on the same day. Steatosis was classified as S0, S1, S2, and S3 on histology, less than 5%, 5% to 33%, 33% to 66%, and greater than 66%, respectively, while the thresholds of 6.4%, 17.4%, and 22.1%, respectively, were used for MRI, PDFF. The area under the curve, AUC, of ATI and CAP, was compared using a DeLong test. Results. Steatosis could be evaluated in 191 and 187 patients with MRI, PDFF, and liver biopsy, respectively. For MRI, PDFF, steatosis, the AUC of ATI and CAP were 0.86, 95% confidence interval, CI, 0.81 to 0.91, versus 0.69, 95% CI, 0.62 to 0.75, for S0 versus S1 S3. P equals 0.02, and 0.71, 95% CI, 0.64 to 0.77, versus 0.69, 95% CI, 0.61 to 0.75, for S0 S1 versus S2 S3, P equals 0.60 respectively. For histological steatosis, the AUC of ATI and CAP were 0.92, 95% CI, 0.87 to 0.95, versus 0.95, 95% CI, 0.91 to 0.98, for S0 versus S1 S3. P equals 0.64, and 0.79, 95% CI, 0.72 to 0.84, versus 0.76, 95% CI, 0.69 to 0.82, for S0, S1 versus S2, S3, p equals 0.61, respectively. Conclusion. ATI may be used as an alternative to CAP for the diagnosis and quantification of steatosis in patients with type 2 diabetes and non-alcoholic fatty liver disease. Misclassified alcohol-related liver disease is common in presumed metabolic dysfunction-associated steatotic liver disease and highly increases risk for future cirrhosis. Background and aims. Alcohol overconsumption is a risk factor for disease progression in patients with presumed metabolic dysfunction-associated steatotic liver disease, MASLD. How commonly this occurs, and how it affects progression to major adverse liver outcomes, MALOs, is not well known. Methods. We did a register-based cohort study, including all patients with a diagnosis of MASLD in Sweden between 1987 and 2020. Patients were stratified on co-occurrence of diagnoses of alcohol-related liver disease, ALD, or alcohol use disorder, AUD, prior to MASLD diagnosis. Incident MALOs were derived from national registers. Cox regression was used to calculate hazard ratios, HRs, for incident MALO. Results. A total of 15,107 patients with MASLD were identified. The median age was 55 years, and 52% were female. Of the patients, 1843, 12%, had a prior diagnosis of ALD or AOD. During follow-up, a further 787 patients, 5.2%, received a diagnosis of ALD or AOD. Patients with previous ALD or AOD diagnoses at or before baseline had considerably higher rates of MALOs compared with patients without, 19.5% versus 7.8%, adjusted HR, 3.12, 95% confidence interval, 2.74 to 3.55. Acquiring an ALD or AOD diagnosis after MASLD diagnosis was associated with higher rates of MALOs. Adjusted HR, 5.81, 95% confidence interval, 4.90 to 6.88. Conclusions. ALD, or AOD, is commonly diagnosed prior to or after MASLD diagnosis. Such patients have considerably higher rates of progression to MALOs. Correctly separating between MASLD and ALD is vital to assess prognosis. Burden of Crohn's disease in the United States Medicaid population, 2010 to 2019. Background and aims. 25% of the United States population is enrolled in Medicaid. Rates of Crohn's disease, CD, have not been estimated in the Medicaid population since the Affordable Care Act expansion in 2014. We aimed to estimate the incidence and prevalence of CD by age, sex, and race. Methods. We identified all 2010 to 2019 Medicaid CD encounters using codes from the International Classification of Diseases, Clinical Modification versions 9 and 10. Individuals with greater than or equal to 2 CD encounters were included. Sensitivity analyses were performed on other definitions, e.g., greater than or equal to 1 CD encounter. Incidence required greater than or equal to 1 year of Medicaid eligibility prior to first CD encounter date, 2013 to 2019. We calculated CD prevalence and incidence using the entire Medicaid population as the denominator. Rates were stratified by calendar year, age, sex, and race. Poisson regression models examined CD-associated demographic characteristics. We compared demographics and treatments of the entire Medicaid population with the multiple CD case definitions using percent and median. Results. A total of 197,553 beneficiaries had greater than or equal to 2 CD encounters. The CD point prevalence per 100,000 persons rose from 56, 2010, to 88, 2011, to 165, 2019. CD incidence per 100,000 person years was 18, 2013, and 13, 2019. Higher incidence and prevalence rates correlated with female, white, or multiracial beneficiaries. Prevalence rates rose in later years, Incidence decreased over time. Conclusions. From 2010 to 2019, Medicaid population CD prevalence increased, while incidence decreased from 2013 to 2019. Overall Medicaid CD incidence and prevalence ranges align with prior large administrative database studies. Next, we will be discussing articles from Clinical Infectious Diseases. The utility of risk factors to define complicated Staphylococcus aureus bacteremia in a setting with low methicillin-resistant S. aureus prevalence. Introduction. Recommended duration of antibiotic treatment of Staphylococcus aureus bacteremia, SAB, is frequently based on distinguishing uncomplicated and complicated SAB, and several risk factors at the onset of infection have been proposed to define complicated SAB. Predictive values of risk factors for complicated SAB have not been validated, and consequences of their use on antibiotic prescriptions are unknown. Methods. In a prospective cohort, patients with SAB were categorized as complicated or uncomplicated through adjudication, reference definition. Associations and predictive values of 9 risk factors were determined, compared with the reference definition, as was Accuracy of Infectious Diseases Society of America, IDSA, criteria that include 4 risk factors, and the projected consequences of applying IDSA criteria on antibiotic use. Results. Among 490 patients, 296, 60%, had complicated SAB. In multivariable analysis, persistent bacteremia, odds ratio, OR, 6.8, 95% confidence interval, CI, 3.9 to 12.0, community acquisition of SAB, OR, 2.9, 95% CI, 1.9 to 4.7, and presence of prosthetic material, OR, 2.3, 95% CI, 1.5 to 3.6, were associated with complicated SAB. Presence of any of the 4 risk factors in the IDSA definition of complicated SAB had a positive predictive value of 70.9%, 95% CI, 65.5 to 75.9, and a negative predictive value of 57.5%, 95% CI, 49.1 to 64.8. Compared with the reference, IDSA criteria yielded 24, 5%, false negative and 90, 18%, false positive classifications of complicated SAB. Median duration of antibiotic treatment of these 90 patients was 16 days, interquartile range, 14 to 19, all with favorable clinical outcome. Conclusions. Risk factors have low to moderate predictive value to identify complicated SAB, and their use may lead to unnecessary prolonged antibiotic use. Outcomes of SARS-CoV-2 Omicron variant infections compare with seasonal influenza and respiratory syncytial virus infections in adults attending the emergency department, a multicentre cohort study. Background. There is a controversy over the impact of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, infections in an era of less virulent variants, and an increasing population immunity. We compared outcomes in adults attending the emergency department, ED, with an Omicron, influenza, or respiratory syncytial virus, RSV, infection. Methods. Retrospective multicenter cohort study, including adults attending the ED in 6 acute care hospitals in Stockholm County, Sweden, with an Omicron, influenza, or RSV infection during 2021 to 2022, and 2015 to 2019. During 2021 to 2022, patients were tested for all 3 viruses by multiplex polymerase chain reaction, PCR, testing. The primary outcome was 30-day all-cause mortality. Secondary outcomes were 90-day all-cause mortality, hospitalization, and intensive care unit, ICU, admission. Results. A total of 6,385 patients from 2021 to 2022 were included in the main analyses: 4,833 Omicron, 1,099 influenza, and 453 RSV. The 30-day mortality was 7.9%, N equals 381. In the Omicron, 2.5%, N equals 28, in the influenza, and 6.0%, N equals 27, in the RSV cohort. Patients with Omicron had an adjusted 30-day mortality odds ratio, or, of 2.36, 95% confidence interval, CI, 1.60 to 3.62, compared with influenza, and 1.42, 95% CI 0.94 to 2.21, compared with RSV. Among unvaccinated Omicron patients, stronger associations were observed compared with both influenza, or 5.51, 95%, CI 3.41 to 9.18, and RSV, or 3.29, 95% CI 2.01 to 5.56. Similar trends were observed for secondary outcomes. Findings were consistent in comparisons with 5,709 pre-pandemic influenza, 995 RSV patients. Conclusions. In patients attending the ED, infections with Omicron were both more common and associated with more severe outcomes compared with influenza and RSV, in particular among unvaccinated patients. Evaluation of 2. The 2023 Duke International Society of Cardiovascular Infectious Diseases criteria in a multicentre cohort of patients with suspected infective endocarditis. Background. Since publication of Duke criteria for infective endocarditis, i.e., diagnosis, several modifications have been proposed. We aimed to evaluate the diagnostic performance of the Duke-ISCVID, International Society of Cardiovascular Infectious Diseases, 2023 criteria compared to prior versions from 2000, Duke-Lee 2000, and 2015, Duke-Escape, European Society for Cardiology, 2015. Methods. This study was conducted at 2 university hospitals between 2014 and 2022 among patients with suspected IE. A case was classified as IE, final IE diagnosis, by the endocarditis team. Sensitivity for each version of the Duke criteria was calculated among patients with confirmed IE, based on pathological, surgical, and microbiological data. Specificity for each version of the Duke criteria was calculated among patients with suspected IE, for whom IE diagnosis was ruled out. Results. In total, 2,132 episodes with suspected IE were included. Definite IE, by pathologic criteria, was found in 285, 13%, 285, 13%, and 345, 16%. Patients using the Duke-Lee 2000, Duke-Escape 2015, or the Duke-ISCVID 2023 criteria, respectively. IE was excluded by histopathology in 25, 1%, patients. The Duke-ISCVID 2023 clinical criteria showed a higher sensitivity, 84%, compared to previous versions, 70%. However, specificity of the new clinical criteria was lower, 60%, compared to previous versions, 74%. Conclusions. The Duke-ISCVID 2023 criteria led to an increase in sensitivity compared to previous versions. Further studies are needed to evaluate items that could increase sensitivity by reducing the number of IE patients misclassified as possible, but without having detrimental effect on specificity of Duke criteria. Next, we will be discussing articles from Journal of Clinical Rheumatology. The relationship between anti-SSA52 and interstitial lung disease. Objective. The aims of this study were to assess whether a relationship between anti-SSA52 and interstitial lung disease, ILD, can be further defined, and to enhance screening, detection, and potentially guide treatment. Methods. A historical cohort study of 201 patients was conducted at a single tertiary care center between January 1, 2016, and December 31, 2020. All included patients were anti-SSA52 antibody positive. Chart review was performed for laboratory values, symptoms, pulmonary function tests, treatment, and imaging. Chest computed tomographies were reviewed by chest radiologists. Results. Among anti-SSA52 antibody-positive patients, ILD was found in 125, 62.2%, compared with 76, 37.8%, with no ILD, p equals 0.001. For those with ILD, 78, 62.4%, were diagnosed with connective tissue disease, CTD-associated ILD, 28, 22.4%, were diagnosed ILD only, and 19, 15.2%, met the criteria for interstitial pneumonia with autoimmune features. In patients with CTD, ILD, 18, 23.0%, had their ILD diagnosis made over 6 months before a CTD diagnosis, and an additional 43, 55.1%, had their ILD and CTD diagnosed within 6 months of each other, p less than 0.001. Common computed tomography patterns were nonspecific interstitial pneumonia/organizing pneumonia overlap in 44, 35.2%, 25, 20.0%, nonspecific interstitial pneumonia, and 15, 12%, usual interstitial pneumonia. 28, 35.9%, had antisynthesis syndrome, followed by 16, 20.5%, with dermatomyositis, 10, 12.8%, with CTD overlap, and 6, 7.7%, with systemic scleroderma. Conclusions. There was a significant association between anti-SSA52 antibodies and ILD across a wide spectrum of rheumatological diagnoses. A significant portion of patients were diagnosed with ILD either at the same time or before their CTD diagnosis. Further study will be needed to assess effective treatment and response. Risk factors for pneumocystis, Girovecchian pneumonia in children with systemic lupus erythematosus exposed to prolonged high-dose glucocorticoids. Background. Pneumocystis jirovecii pneumonia, PJP, is a life-threatening opportunistic infection in immunocompromised children with systemic lupus erythematosus, SLE. Prophylaxis against PJP in high-risk children is crucial, but the risk factors for PJP in children with SLE are not adequately characterized. This study sought to identify the risk factors for PJP in long-term glucocorticoid-treated pediatric SLE patients. Methods. This study encompassed 71 treatment episodes involving 64 children with prolonged, greater than or equal to 4 weeks, high dose, greater than or equal to 20 mg/d-prednisone steroid regimens. 14 treatment episodes involved the PJP, whereas others did not. Risk factors for PJP were assessed through Cox regression. The predictive value of these factors was evaluated using receiver operating characteristic curves. The incidence of PJP in different risk groups was compared using the Kaplan-Meier method. Results. The creatinine hazard ratio, 1.009, 95% confidence interval, CI, 1.001 to 1.017, p equals 0.021, and the lowest lymphocyte count hazard ratio, 0.007, 95% CI, 0.000 to 0.373, p equals 0.014, were independent risk factors for PJP in children with SLE. The receiver operating characteristic curve showed that using creatinine greater than 72.5 mol/L and the lowest lymphocyte count less than 0.6 times 10^9/L as risk predictors for PJP resulted in an area under the curve value of 0.934, 95% CI, 0.870 to 0.997, p less than 0.001. The study revealed a significant increase in PJP prevalence, p less than 0.001, in children with elevated creatinine levels and low lymphocyte count. Conclusions. Elevated levels of creatinine, decreased lymphocyte count, are identified as distinct risk factors for PJP in children with SLE who receive prolonged high-dose steroid therapy. Next, we will be discussing articles from Arthritis and Rheumatology. Using polygenic risk scores to aid diagnosis of patients with early inflammatory arthritis, results from the Norfolk Arthritis Register. Objective: there is growing evidence that genetic data are of benefit in the rheumatology outpatient setting by aiding early diagnosis. A genetic probability tool, gProb, has been developed to aid diagnosis, has not yet been tested in a real-world setting. Our aim was to assess whether gProb could aid diagnosis in the rheumatology outpatient setting using data from the Norfolk Arthritis Register, NOAR, a prospective observational cohort of patients presenting with early inflammatory arthritis. Methods: genotypes and clinician diagnoses were obtained from patients from NOR. 6G probabilities, 0% to 100%, were created for each patient based on known disease-associated odds ratios of published genetic risk variants, each corresponding to one disease of rheumatoid arthritis, systemic lupus erythematosus, psoriatic arthritis, spondyloarthropathy, gout, or other diseases. Performance of the G probabilities compared with clinician diagnosis was assessed. Results: we tested gProb on 1,047 patients. Calibration of G probabilities with clinician diagnosis was high, with regression coefficients of 1.047, where 1.00 is ideal. G probabilities discriminated clinician diagnosis with pooled areas under the curve, 95% confidence interval of 0.85, 0.84 to 0.86. G probabilities less than 5% corresponded to a negative predictive value of 96.0%, for which it was possible to suggest greater than 2 unlikely diseases for 94% of patients, and greater than 3 for 53.7% of patients. G probabilities greater than 50% corresponded to a positive predictive value of 70.4%. In 55.7% of patients, the disease with the highest G probability corresponded to clinician diagnosis. Conclusion: gProb converts complex genetic information into meaningful and interpretable conditional probabilities, which may be especially helpful at eliminating unlikely diagnoses in the rheumatology outpatient setting. Next, we will be discussing articles from Circulation. Directed differentiation of human-induced pluripotent stem cells to heart valve cells. Background: a main obstacle in current valvular heart disease research is the lack of high-quality homogeneous functional heart valve cells. Human-induced pluripotent stem cells, HIPSCs, derived heart valve cells may help with this dilemma. However, there are no well-established protocols to induce HIPSCs to differentiate into functional heart valve cells, and the networks that mediate the differentiation have not been fully elucidated. Methods: to generate heart valve cells from HIPS, we sequentially activated the WNT, BMP4, VEGF, vascular endothelial growth factor, and NFATK1 signaling pathways using CHIR 99021, BMP4, VEGF 165, and forskolin, respectively. Results: an efficient protocol was developed to induce HIPSCs to differentiate into functional HIPSC-derived valve endothelial-like cells and HIPSC-derived valve interstitial-like cells. After 6-day differentiation and CD144 magnetic bead sorting, 70% CD144 plus cells and 30% CD144 cells were obtained. On the basis of single-cell RNA sequencing data, the CD144 plus cells and CD144 cells were found to be highly similar to primary heart valve endothelial cells and primary heart valve interstitial cells in gene expression profile. Furthermore, CD144 plus cells had the typical function of primary heart valve endothelial cells, including tube formation, uptake of low-density lipoprotein, generation of endothelial nitric oxide synthase, and response to shear stress. Meanwhile, CD144 cells could secrete collagen and matrix metalloproteinases, and differentiate into osteogenic or adipogenic lineages, like primary heart valve interstitial cells. Therefore, we identified CD144 plus cells and CD144 cells as HIPSC-derived valve endothelial-like cells and HIPSC-derived valve interstitial-like cells, respectively. Using single-cell RNA sequencing analysis, we demonstrated that the trajectory of heart valve cell differentiation was consistent with embryonic valve development. We identified the main switch genes, Notch1, HEY1, and MEF2C, signaling pathways, TGF-beta, WNT, and Notch, and transcription factors, MSX1, SP5, and MACOM, that mediated the differentiation. Finally, we found that HIPSC-derived valve interstitial-like cells might derive from HIPSC-derived valve endothelial-like cells undergoing endocardial mesenchymal transition. Conclusions. In summary, this is the first study to report an efficient strategy to generate functional HIPSC-derived valve endothelial-like cells and HIPSC-derived valve interstitial-like cells from HIPSC, as well as to elucidate the differentiation trajectory and transcriptional dynamics of HIPSCs differentiated into heart valve cells. Next, we will be discussing articles. American College of Cardiology. Cardiomyopathies in Children and Adolescents. Study questions. What are the baseline characteristics and one-year outcomes of children and adolescents with cardiomyopathy? Methods. The European Society of Cardiology Euro-Observational Research Program, ESCAPE-EORP, Cardiomyopathy and Myocarditis Long-Term Registry, was used to collect prospective data on individuals aged 1 to less than 18 years. Results. A total of 633 individuals, aged less than or equal to 18 years, with hypertrophic, HCM, N equals 388, 61.3%, dilated, DCM, N equals 206, 32.5%, restrictive, RCM, N equals 28, 4.4%, and arrhythmogenic right ventricular cardiomyopathy, N equals 11, 1.7%, were enrolled by 23 centers in 14 countries. Median age at diagnosis was 4 years, and there was a male predominance, 58.8%, across all subtypes, with the exception of DCM diagnosed at less than 10 years of age. Familial disease was present in 47.3% of patients. Genetic testing was performed in 67.8% of patients, with a pathogenic or likely pathogenic variant in 60.4%. Over a median follow-up of 12.5 months, 18 patients, 3.3%, died. HCM N equals 9, 2.6%, DCM N equals 5, 3%, RCM N equals 4, 16.0%. Heart failure events were most frequent in RCM patients, 36.0%. Conclusions. The authors conclude that childhood cardiomyopathies are heterogeneous in etiology, and that there is a high frequency of familial disease. Outcomes differ by cardiomyopathy subtype, emphasizing the need for disease-specific evaluation and treatment. Perspective. This study made use of the European ESCAPE-EORP cardiomyopathy and myocarditis registry. Genetic testing in this patient population is relatively high yield, demonstrating a pathogenic variant in over 60% of patients tested. In comparison with registries in North America and Australia, HCM, as opposed to DCM, was the most frequent diagnosis. This may be related to the exclusion of patients less than 1 year of age in this registry, as DCM is more common in infants. It is also possible that HCM may be more common than previously known. Moving forward, the registry will continue to provide helpful information regarding characteristics and natural history of the various types of cardiomyopathy in children. Next, we will be discussing articles from journals of the American College of Cardiology. Association of lipoprotein levels with myocardial infarction in patients with low attenuation plaque. Background. Lipoprotein A, LPA, is associated with an increased risk of myocardial infarction, MI. However, the mechanism underlying this association has yet to be fully elucidated. Objectives. This multicentre study aimed to investigate whether association between LPA and MI risk is reinforced by the presence of low attenuation plaque, LAP, identified by coronary computed tomography angiography, CCTA, methods. In a derivation cohort, a total of 5,607 patients, with stable chest pain suspected of coronary artery disease, who underwent CCTA and LP, a measurement, were prospectively enrolled. In validation cohort, 1,122 patients were retrospectively collected during the same period. High LPA was defined as LP a greater than or equal to 50 mg/dl. The primary endpoint was a composite of time to fatal or non-fatal MI. Associations were estimated using multivariable Cox proportional hazard models. Results. During a median follow-up of 8.2 years, Q1-Q3, 7.2 to 9.3 years, the elevated LPA levels were associated with MI risk. Adjusted HR, AHR, 1.91, 95% CI, 1.46 to 2.49, p less than 0.001. There was a significant interaction between LPA and LAP, interaction less than 0.001, in relation to MI risk. When stratified by the presence or absence of LAP, LPA was associated with MI in patients with LAP, AHR, 3.03, 95% CI, 1.92 to 4.76, p less than 0.001. Mediation analysis revealed that LAP mediated 73.3%, p less than 0.001, for the relationship between LPA and MI. The principal findings remained unchanged in the validation cohort. Conclusions. Elevated LPA augmented the risk of MI during 8 years of follow-up, especially in patients with LAP identified by CCTA. The presence of LAP could reinforce the relationship between LPA and future MI occurrence. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Characterizing genetic alterations related to radioiodine avidity in metastatic thyroid cancer. Context. Patients with differentiated thyroid cancer, DTC, with distant metastasis, DM, are usually not recognized as radioactive iodine, RAI refractory DTC, in a timely manner. The elucidation of genetic features related to RAI uptake patterns may shed light on the early recognition of RAI refractory DTC. Objective. This work aimed to elucidate the underlying molecular features behind different RA uptake patterns. Methods. A total of 214 patients with DM-DTC were retrospectively included in the analysis. RA uptake patterns were defined as initially RA refractory, I-rare, and initially RA-avid, I-RIA. According to the first post-treatment scan, then I-RIA was further divided into continually RIA, C-RIA, partly rare, P-rare, and gradually rare, G-rare, according to subsequent scans. The molecular subtype groups, BRAF 600E mutated, RAS mutated, fusions, and others, were classified according to main driver gene status. Results. BRAF, TERT promoter, and TP53 mutations are more frequently detected in the I-rare pattern, while RET fusions and RAS mutations are more frequent in the I-RIA pattern. A late hit mutation, including TERT, TP53, or PICA, is more common in I-rare than that in I-RIA, 50.0% versus 26.9%. P equals 0.001, particularly for those with RAS mutations in the I-rare group, always accompanied by TERT promoter. Isolated RET fusions accounts for 10% of I-rare. When compared among driver gene groups, BRAF 600E mutated tumors have a higher rate of the I-rare pattern, 64.4%, than RAS mutated, 4.5%, P less than 0.001, and fusion positive, 20.7%, P less than 0.001, tumors. In I-RIA subgroups, BRAF 600E mutated tumors have lower prevalence of the C-RIA pattern than those with RAS mutation or fusions. Conclusion. Patients with the I-rare pattern predominantly featured mutations of the BRAF and/or TERT promoter, of which RAS mutations were usually accompanied by late hit mutations, while fusions mostly occurred alone. Defective visceral adipose tissue, adaptation in gestational diabetes mellitus. Context. Gestational diabetes mellitus, GDM, is a complex obstetric condition affecting localized glucose metabolism, resulting in systemic metabolic dysfunction. Objective. This cross-sectional study aimed to explore visceral adipose tissue, VAT, as an integral contributor to GDM, focusing on elucidating the specific contribution of obesity and GDM pathology to maternal outcomes. Methods. 56 nulliparous pregnant women were recruited, including normal glucose tolerant, NGT, N equals 30, and GDM, N equals 26, participants. Participants were subgrouped as non-obese, BMI less than 30 kg/m2, or obese, BMI greater than or equal to 30 kg/m2. Metabolic markers in circulation, VAT, and placenta were determined. Morphological analysis of VAT and immunoblotting of the insulin signaling cascade were performed. Results. GDM participants demonstrated hyperinsulinemia and elevated homeostatic model assessment for insulin resistance, HOMA-IR, scores relative to NGT participants. This is GDM obese subgroup had significant VAT adipocyte hypoplasia relative to NGT non-obese tissue. GDM obese VAT had significantly lower insulin receptor substrate, IRS-2 expression, with elevated SIR312 phosphorylation of IRS1 relative to NGT non-obese. GDM obese participants had significantly elevated circulating leptin levels and placental adipsin secretion, while GDM non-obese participants had elevated circulating adipsin levels with reduced placental adiponectin secretion. Conclusion. These findings suggest that GDM obese pregnancy is specifically characterized by inadequate VAT remodeling and dysfunctional molecular signaling, which contribute to insulin resistance and hinder metabolic health. Next, we will be discussing articles from Neurology. Covert cerebrovascular changes in people with heart disease, a systematic review and meta-analysis. Background and objectives. To determine the prevalence of silent brain infarction, SBI, and cerebral small vessel disease, CSVD, in adults with atrial fibrillation, AF, coronary artery disease, heart failure or cardiomyopathy, heart valve disease, and patent foramen ovale, PFO, with comparisons between those with and without recent stroke, and an exploration of associations between heart disease and SBI/CSVD. Methods. Medline, Embase, and Cochrane Library were systematically searched for hospital-based or community-based studies reporting SBI/CSVD in people with heart disease. Data were extracted from eligible studies. Outcomes were SBI, primary, and individual CSVD subtypes. Summary prevalence. 95% confidence intervals, Cs, were obtained using random effects meta-analysis. Pooled prevalence ratios, PRs 95% CI, were calculated to compare those with heart disease with available control participants without heart disease from studies. Results. A total of 221 observational studies were included. In those with AF, the prevalence was 36%, 31% to 41%, for SBI, 70 studies, N equals 13,589, 25%, 19% to 31%, for Lacoon, 26 studies, N equals 7,172, 62%, 49% to 74%, for white matter hyperintensity/hypoattenuation, WMH, 34 studies, N equals 7,229, and 27%, 24% to 30%, for microbleed, 44 studies, N equals 13,654. Stratification by studies where participants with recent stroke were recruited identified no differences in the prevalence of SBI across subgroups. Homogeneity equals 0.495. Results were comparable across participants with different heart diseases, except for those with PFO, in whom there was a lower prevalence of SBI. 21%, 13% to 30%, 11 studies, N equals 1,053, and CSVD. Meta-regressions after pooling those with any heart disease identified associations of increased study level, age, and hypertensives, with more SBIs and WMH, progression less than 0.05. There was no evidence of a difference in the prevalence of microbleed between those with and without heart disease. PR 95% CI 1.1, 0.7 to 1.7. But a difference was seen in the prevalence of SBI and WMH. PR 95% CI 2.3, 1.6 to 3.1, and 1.7, 1.1 to 2.6, respectively. Discussion. People with heart disease have a high prevalence of SBI and CSVD, which is similar in those with versus without recent stroke. More research is required to assess causal links and implications for management. Next, we will be discussing articles from Chest. Longitudinal effects of elexacaftor/tezacaftor/ivacaftor. Background. Italy initiated elexacaftor/tezacaftor/ivacaftor, ETI, for people with cystic fibrosis, PWCF, in July 2021. It has led to dramatic improvements in lung function, BMI, sweat chloride, and respiratory symptoms. However, few data are available on side effects or effects on a broad range of outcomes. Research question. How does ETI affect mental health, cognitive processing, neuropsychological side effects, GI symptoms, and health-related quality of life over time? Study design and methods. This was a prospective, real-world longitudinal study. Participants were recruited consecutively and evaluated at initiation, T0, and after 1 month, 3 months, and 6 months of starting treatment. Assessments included depression, 9-item patient health questionnaire, anxiety, 7-item generalized anxiety disorder, cognition, symbol-digit modalities test, GI symptom tracker, and health-related quality of life. Cystic fibrosis questionnaire revised. Based on literature, an ad hoc questionnaire was developed to assess side effects, insomnia, headache, memory problems, brain fog, and concentration problems. Following descriptive analyses, longitudinal data were analyzed by using mixed models for repeated measures, controlling for age and sex when appropriate. Results. 92 consecutive PWCF, female/male, 46-46, mean age, 25.4 years, participated. FEV1 increased initially, and then remained stable. BMI also increased significantly from T0 to 6 months, P less than 0.01. Depression improved from T0 to 1 month, P less than 0.001. However, no changes in anxiety were found. Cognitive processing improved from T0 to subsequent assessments. Positive changes were reported on the GI symptom tracker for stools and adherence challenges, although no changes were found for abdominal pain and digestion. Side effects occurred in 10% to 29%, with no reduction over time. Insomnia increased significantly across time. Female participants reported more side effects than male participants, insomnia, headache, concentration problems, brain fog. Interpretation. This prospective study evaluated the effects of ETI using multiple measures. Significant improvements were found in many domains. However, side effects were reported by a substantial proportion of PWCF, with no improvements over time. Female participants reported more side effects than male participants. PWCF should be followed up systematically to assess the frequency of side effects after starting this new modulator. Etiology-based prognosis of extracorporeal CPR recipients after out-of-hospital cardiac arrest. Background. A better understanding of the relative contributions of various factors to patient outcomes is essential for optimal patient selection for extracorporeal CPR, ECPR, therapy for patients with out-of-hospital cardiac arrest, OHCA. However, evidence on the prognostic comparison based on the etiologies of cardiac arrest is limited. Research question. What is the etiology-based prognosis of patients undergoing ECPR for OCA? Study design and methods. This retrospective multicentre registry study involved 36 institutions in Japan and included all adult patients with OCA who underwent ECPR between January 2013 and December 2018. The primary etiology for OCA was determined retrospectively from all hospital-based data at each institution. We performed a multivariable logistic regression model to determine the association between etiology of cardiac arrest and two outcomes: favorable neurologic outcome and survival at hospital discharge. Results: we identified 1,781 eligible patients, of whom 1,405, 78.9%, had cardiac arrest because of cardiac causes. Multivariable logistic regression analysis for favorable neurologic outcome showed that accidental hypothermia, adjusted O, 5.12, 95% CI, 2.98 to 8.80, p less than 0.001, was associated with a significantly higher rate of favorable neurologic outcome than cardiac causes. Multivariable logistic regression analysis for survival showed that accidental hypothermia, adjusted OR, 5.19, 95% CI, 3.15 to 8.56, p less than 0.001, had significantly higher rates of survival than cardiac causes. Acute aortic dissection/aneurysm, adjusted OR, 0.07, 95% CI, 0.02 to 0.28, p less than 0.001, and primary cerebral disorders, adjusted OR, 0.12, 95% CI, 0.03 to 0.50, p equals 0.004, had significantly lower rates of survival than cardiac causes. Interpretation: in this retrospective multicentre cohort study, although most patients with OCA underwent ECPR for cardiac causes, accidental hypothermia was associated with favorable neurologic outcome and survival. In contrast, acute aortic dissection/aneurysm and primary cerebral disorders were associated with non-survival compared with cardiac causes. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Commensal oral microbiota, disease severity, and mortality in fibrotic lung disease. Rationale: oral microbiota associate with diseases of the mouth and serve as a source of lung microbiota. However, the role of oral microbiota in lung disease is unknown. Objectives: to determine associations between oral microbiota and disease severity and death in idiopathic pulmonary fibrosis, IPF. Methods: we analyzed 16S RNA gene and shotgun metagenomic sequencing data of buccal swabs from 511 patients with IPF in the multicentre cleanup IPF study of clinical efficacy of antimicrobial therapy strategy using pragmatic design in IPF trial. Buccal swabs were collected from usual care and antimicrobial cohorts. Microbiome data were correlated with measures of disease severity using principal component analysis and linear regression models. Associations between the buccal microbiome and mortality were determined using Cox additive models, Kaplan-Meier analysis, and Cox proportional hazards models. Measurements and main results: greater buccal microbial diversity associated with lower FVC at baseline, mean difference, -3.60, 95% confidence interval, CI, -5.92 to -1.29%, predicted FVC per 1 unit increment. The buccal proportion of Streptococcus correlated positively with FVC, mean difference, 0.80, 95% CI, 0.16 to 1.43% predicted per 10% increase, N equals 490. Greater microbial diversity was associated with an increased risk of death, hazard ratio, 1.73, 95% CI, 1.03 to 2.90, whereas a greater proportion of Streptococcus was associated with a reduced risk of death, HR, 0.85, 95% CI, 0.73 to 0.99. The Streptococcus genus was mainly composed of Streptococcus mitis species. Conclusions: increasing buccal microbial diversity predicts disease severity and death in IPF. The oral commensal S. mitis SPP associates with preserved lung function and improved survival. Alveolar hemorrhage, an antineutrophil cytoplasmic antibody-associated vasculitis, Results of an international randomized controlled trial, PEXAVA's rationale, diffuse alveolar hemorrhage, DAH, is a life-threatening manifestation of anti-neutrophil cytoplasmic antibody-associated vasculitis, AAV. The PEXAVAs, plasma exchange and glucocorticoids in severe antineutrophil cytoplasmic antibody-associated vasculitis, NCT 009-87389, trial was the largest in A.I.V. and the first to enroll participants with DAH requiring mechanical ventilation. Objectives: evaluate characteristics, treatment effects, and outcomes for patients with A.I.V. with and without DAH. Methods: PEXAVAs randomized 704 participants to plasma exchange, PLEX, or no-plex and reduced or standard dose glucocorticoids, GC. DA status was defined at enrollment as no-DA. Non-severe, or severe, room air oxygen saturation of 85%, as measured by pulse oximetry, or use of mechanical ventilation. Measurements and main results: at enrollment, 191, 27.1%. Participants had DAH, 61 severe, including 29 ventilated, and were younger, more frequently relapsing, PR3, proteinase 3 oncopositive, and had lower serum creatinine, but were more frequently dialyzed than participants without DAH, N equals 513, 72.9%. Among those with DAA, 895, 8.4%, receiving PLEX died within 1 year versus 1596, 15.6%, with no PLEX, hazard ratio, 0.52, confidence interval, CI, 0.21 to 1.24, whereas 1396, 13.5%, receiving reduced GC died versus 1095, 10.5%, with standard GC, hazard ratio, 1.33, CI, 0.57 to 3.13. When ventilated, ventilator-free days were similar with PLEX versus no PLEX. Medians, 25. Interquartile range, IQR, 22 to 26, versus 22 to 27. And fewer with reduced GC, median, 23, IQR, 20 to 25, versus standard GC, median, 26, IQR, 25 to 28. Treatment effects on mortality did not vary by presence or severity of DAH. Overall, 23,191, 12.0%, with DAH died within 1 year versus 34,513, 6.6%, without DAH. End-stage kidney disease and serious infections did not differ by DAH status or treatments. Conclusions: patients with A.I.V. and DAH differ from those without DA in multiple ways. Further data are required to confirm or refute a benefit of PLEX or GC dosing on mortality. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Histologic and clinical factors associated with kidney outcomes in IgA vasculitis nephritis. Background: nephritis is a common manifestation of IgA vasculitis and is morphologically indistinguishable from IgA nephropathy. While MEST C-scores are predictive of kidney outcomes in IgA nephropathy, their value in IgA vasculitis nephritis has not been investigated in large multi-ethnic cohorts. Methods: biopsies from 262 children and 99 adults with IgA vasculitis nephritis, N equals 361, from 23 centers in North America, Europe, and Asia, were independently scored by 3 pathologists. MEST C-scores were assessed for correlation with EGFR/proteinuria at biopsy. Because most patients, N equals 309, 86%, received immunosuppression, risk factors for outcomes were evaluated in this group, using latent class mixed models to identify classes of EGFR trajectories over a median follow-up of 2.7 years. Interquartile range, 1.2 to 5.1. Clinical and histologic parameters associated with each class were determined using logistic regression. Results: M, E, T, and C scores were correlated with either EGFR or proteinuria at biopsy. 2 classes were identified by latent class mixed model, one with initial improvement in EGFR, followed by a late decline, class 1, N equals 91, and another with stable EGFR, class 2, N equals 218. Class 1 was associated with a higher risk of an established kidney outcome. Time to greater than or equal to 30% decline in EGFR or kidney failure, hazard ratio, 5.84. 95% confidence interval, 2.37 to 14.4. Among MEST C-scores, only E1 was associated with Class 1 by multivariable analysis. Other factors associated with Class 1 were age 18 years and younger, male sex, lower EGFR at biopsy, and extrarenal non-cutaneous disease. Fibrous crescents without active changes were associated with Class 2. Conclusions. Kidney outcome in patients with biopsied IgA vasculitis. Nephritis treated with immunosuppression was determined by clinical risk factors and endocapillary hypercellularity, E1, and fibrous crescents, which are features that are not part of the International Study of Diseases of Children classification. Associations of changes in bone turnover markers with change in bone mineral density in kidney transplant patients. Background. Bone loss after kidney transplantation is highly variable. We investigated whether changes in bone turnover markers associate with bone loss during the first post-transplant year. Methods. Bone mineral density, BMD, was measured at 0 and 12 months, with biointact parathyroid hormone, bone-specific alkaline phosphatase, BALP, intact procollagen type IN terminal propeptide, PIMP, and tartrate-resistant acid phosphatase isoform 5B, TRAP5B, measured at 0, 3, and 12 months post-transplant, N equals 209. Paired transiliac bone biopsies were available in a subset, N equals 49. Between group differences were evaluated by students' t-test, Wilcoxon-signed rank test, or Pearson's chi-squared test. Results. Changes in BMD varied from -22% to +17% compared with patients with no change, ±2, 5% patients who gained BMD had higher levels of parathyroid hormone, 236 versus 136 pg/mls, BALP, 31.7 versus 18.8 μgl, and intact PIMP, 121.9 versus 70.4 μgl. At time of transplantation, a greater decrease in BALP, -40% versus -21%, and intact PIMP, -43% versus -13%. By 3 months, and lower levels of intact PIMP, 36.3 versus 60.0 μgl, at 12 months post-transplant. Patients who lost BMD had a less marked decrease, or even increase, in intact PIMP, +22% versus -13%, and TRAP5B, -27% versus -43%, at 3 months, and higher intact PIMP, 83.7 versus 60.0 μgl, and TRAP5B, 3.89 versus 3.16 UL, at 12 months, compared with patients with no change. If none of the biomarkers decreased by the least significant change at 3 months, an almost twofold, 69% versus 36%, higher occurrence of bone loss was seen at 12 months post-transplant. Conclusions. Bone loss after kidney transplantation was highly variable. Resolution of high bone turnover, as reflected by decreasing bone turnover markers, associated with BMD gain, while increasing bone turnover markers associated with bone loss. Next, we will be discussing articles is from Kidney International Reports. Associations between prematurity, birth weight, and adolescence blood pressure in a nationwide cohort. Introduction. Prematurity is associated with incomplete nephrogenesis and an increased incidence of acute kidney injury that may increase the risk of future kidney disease, including hypertension, proteinuria, and reduced glomerular filtration rate. The aim of this study was to evaluate the risk of hypertension or proteinuria in adolescents born prematurely or small, for gestational age, in a nationwide cohort. Methods. The study cohort included potential recruits examined in the Israel Defense Forces, IDF, medical facilities, between November 2005 and October 2018. Clinical and anthropometric data, including blood pressure, BP, measurement, were retrieved from the IDF medical files. Adolescents born between January 1993 and December 2000 had additional data on gestational age at birth, retrieved from the Israeli Ministry of Health database. Results. The study cohort included 513,802 participants, aged 17.3 plus or minus 0.9 years, of whom 48,994 had gestational age data. Adolescents born as very preterm, as extremely preterm infants, those born with very low birth weight, VLBW, or with extremely low birth weight, ELBW, had higher incidence of hypertensive range BP, 55%, 47%, 19%, and 12%, respectively. No significant association between birth weight, BW, adjusted to gestational age and hypertension was observed. Within the overweight and obese adolescents, those born with VLBW and ELBW had further increased hypertensive range BP rate. Proteinuria was diagnosed in 0.33% of the study cohort, with no significant difference between BW or gestational age categories. Conclusion. Adolescents born with VLBW or as significant preterm were associated with high BP and should be monitored for hypertension development and its potential complications. A prospective study of the association between plasma calprotectin levels and new-onset CKD in the general population. Introduction. Systemic inflammation has been associated with chronic kidney disease, CKD. In this study, we aimed to investigate a potential association between the plasma biomarker of inflammation calprotectin and new-onset CKD in a population-based cohort study. Methods. Individuals without CKD at baseline, N equals 4,662, who participated in the prevention of renal and vascular end-stage disease, PREVEND, prospective population-based cohort study in the Netherlands, were included. Baseline plasma calprotectin levels were assessed in samples that had been stored at -80 degrees Celsius. Occurrence of new-onset CKD was defined as a composite outcome of an estimated glomerular filtration rate, EGFR, less than 60 milliliters per minute per 1.73 square meters, urinary albumin excretion, UAE, greater than 30 milligrams/24 hours, or both. Results. Baseline median, interquartile range. Plasma calprotectin levels were 0.49, 0.35 to 0.68 mg/L and baseline median EGCFR was 95.9. Interquartile range, 85.0 to 105.7 metamol per minute per 1.73 square meters. After median follow-up of 8.3, 7.8 to 8.9 years, 467 participants developed new-onset CKD. Baseline plasma calprotectin levels were significantly associated with an increased risk of new-onset CKD. Hazard ratio, HR, per doubling 1.28, 95% confidence interval, CI, 1.14 to 1.44, p less than 0.001. Independent of potentially confounding factors, HR, 1.14, 95% CI, 1.01 to 1.29, p equals 0.034. Except for baseline high-sensitive C-reactive protein, HSCRP, HR 1.05, 0.91 to 1.21, p equals 0.494. In secondary analyses, the association between plasma calprotectin and occurrence of UAE, greater than 30 milligrams/24 hours, remained significant. HR 1.17, 1.02 to 1.34, p equals 0.027, but not significantly so for the incidence of EGFR less than 60 milliliters per minute per 1.73 square meters as individual outcome. HR 1.15, 0.92 to 1.43, p equals 0.218. Conclusion. Higher plasma calprotectin levels are associated with an increased risk of developing CKD in the general population. This association is mitigated after adjustment for HSCRP, and more pronounced with new onset CKD, defined by UAE.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.